Thank you, Ehlers.
You're welcome, dear Mahia. And I think in 2 minutes we are going to start the session, yes?
Yeah. Waiting patiently to start.
So what's the order of the presentations?
Dear Professor, we will start with Dr. Bernal, then Dr. Scott, then we will start in your presentation and we will finish the session with Dr. Leahy.
Okay, perfect. Thank you.
Thank you. Thank you.
So is everyone doing it live or is it all filmed?
We will have your lecture live, Dr. Bernal live. Unfortunately, an emergency problem happened to Dr. Scott, so we lost him about 15 minutes ago. And Dr. Leahy will join us at the end of her lecture and join our Q&A session.
Okay, great.
Thank you.
Dear Mahia, I'm muting myself and start sharing.
Thank
Have
you.
a good luck.
Thank you.
Have a good
Thank
event.
You. Hi, Lar. Hi, Lar. Please start the clip.
It is started.
No, it's not.
Okay, so. Okay, dear Dr. Memor.
Yeah, thank you. Hello, good morning, good evening, and good night to all dear friends, colleagues from all around the world. Here we are back with the third day of the amazing 33rd International Congress on Pediatrics. Thanks for joining us. I'm so excited. I'm Dr. Mahia Qahramanlu, pediatric resident at Tehran University of Medical Sciences, and I'm so excited, so proud to be a part of the amazing executive team of the Congress. I'm so glad to be here. Thank you for joining us, and we are going to have two particular sessions today on pediatric rheumatology. I will be here with you, and I'm so glad that you joined us. Thank you, dear Professor Ravali, dear Dr. Sadeghi, for arranging this amazing day for us. Thank you again for joining us, and Dear participants, please pay attention to these little notes that I mentioned. Please make sure that your microphone is muted, your video is off, and please log in with your real full name in English. Please do not forget to register on our web application of the Congress. And again, please log in with your full name in English. You will receive the certificate of attendance within 7 days in English. The list of participants in Zoom, the list of Zoom audiences will be matched with the list of registered applications on web application in order to receive your certificate. And also, dear Iranian participants, please do not forget to receive your CME credit after finishing this session. So please join the exam at ircme.ir. Let's get starting our amazing first session of pediatric rheumatology. We will start with amazing topic on systematic lupus erythematosus. Dear Professor Christine B. Bernal is a pediatrician and rheumatologist in Green Hills, North San Juan, and has experience of 19 years in these fields. Dr. Christine B. Bernal practiced as Cardinal Santo Medical Center in Green Hills, North San Juan, and University of Santo Tomas Hospital in São Paulo, Manila. She completed Doctor of Medicine from University of Santo Tomas in 1998. She is Associate Professor of Pediatrics and Chief of Pediatric Rheumatology Department at UST Hospital and Cardinal Santos Medical Centers, University of Santo Tomas, Manila, Philippines. Dear Professor Bernal, I can see you here.
Yes, I'm here. Thank you very much for the kind introduction. So can I share my slides now?
Yeah, you are co-host, and so many thanks for accepting our invitation. Thanks for joining us, and I'm sure that we are going to have an amazing day with your lecture.
Okay, so good day to everyone. Is my voice clear to everyone?
Yeah, your voice is completely clear.
Okay, so first of all, I'd like to thank the Scientific Committee for inviting me to talk in this International Congress in Pediatrics. It's an honor for me to be here. So I was tasked to give this presentation on the clinical heterogeneity of systemic lupus erythematosus. Since I'm 4,500 miles away from the audience, allow me to show you the place where I am currently teaching. So this is University of Santo Tomas, established in 1611 and known as the oldest Catholic university in Asia. The Faculty of Medicine and Surgery, as you can see on your right, is actually the biggest in the country and is in existence for 150 years, while the hospital was established in 1946. I have no disclosure relevant to this presentation. Systemic lupus erythematosus is an immune-mediated disease with multi-systemic involvement and variable manifestations. The spectrum of disease presentation and course can be mild, with long quiescent spaces, to severe disease with frequent flares. It is a chronic lifelong disease that requires long-term immunosuppression and may lead to considerable organ damage. The exact cause of lupus remains unknown, but genetic and environmental factors play a significant role in the development of the disease. But the interplay between these factors remains poorly understood at the patient level. Several factors, including familial clustering, ethnicity distribution, age-specific differences in clinical and laboratory phenotypes when compared to adult patients with lupus, suggest variable pathogenic mechanisms between age groups, and a stronger involvement of genetic factors in childhood. The influence of race in lupus has been well stated. We now know that when compared to Caucasians, African Americans have a higher predisposition to lupus, with a higher rate of lupus nephritis, with worse severity in terms of damage accrual and health-related quality of life outcomes, and in fact, 3 times higher rate of mortality. Another study also showed that Black, African, and Caribbean with childhood onset lupus presented a diagnosis with the more classical features when compared to white Caucasian and Asian patients, while Asians, when compared to the white populations, were found to be more prone to serious clinical manifestations with poorer outcome. In terms of treatment response to mycophenolate mofetil, a study proved that Black and Hispanic patients with lupus nephritis responded better compared to Caucasian patients. What about age? Studies comparing childhood onset lupus in different age groups show that patients who were diagnosed very early, before the age of 5, were more likely to display an atypical presentation, more severe disease course, and poor outcome, while patients diagnosed in the adolescent stage displayed the more classic lupus phenotype. As an example, this table lifted from a study published in Lupus show that patients whose onset of lupus was at less than 2 years of age presented with more involvement of the cardiorespiratory system and the presence of anemia and thrombocytopenia compared to those who were above 2 years of age. Although symptoms, pathogenesis, and immunological findings of childhood lupus are similar to those of adult patients, comparative studies have consistently reported that children have higher mean lupus activity disease scores at presentation and over time. They have higher frequency of nephritis, eventually ending up with more frequent and prolonged use of immunosuppressive therapies and more rapid development of damage. These observations are very important as they are likely to cause an increased risk of cumulative damage and consequently early morbidity and mortality. Childhood SLE represents around 10 to 20% of SLE cases, with an incidence of 0.36 to 2.5 per 100,000 and a prevalence of 1.8 to 34.1. The median age at onset is 10 to 12 years of age. Looking at the data from our own lupus database, which include a little over 2,000 patients, 20% had the disease before the age of 19, with a median age of 11 to 12. Diagnosis and treatment of lupus can be difficult and is complicated by marked heterogeneity between individual patients in terms of disease presentation and progression, treatment response, and in their overall disease severity. Hence, we always say that there are no 2 lupus patients that are the same. Childhood lupus more frequently presents as an insidious chronic illness, while some will present with an acute rapidly fatal disease rather. Majority of these patients will show constitutional symptoms of fever, fatigue, weight loss, and anorexia. In the next slides, I will talk on the systemic manifestations of SLE. Mucocutaneous is the most common initial presentation across all age groups, which is classified as acute, subacute, and chronic. The most common is the malar or butterfly rash, described as erythematous raised rash, on the malar area that crosses the nasal bridge but spares the nasolateral fold. This is present in 40 to 50% of patients. Next is discoid rash, which are plaques commonly seen on the face and scalp. They do hyperpigment and scar over time. Third is carrying alopecia, and the last is oral ulcers, which are painless ulcers seen over the palate. The rash of lupus is photosensitive in nature, hence are frequently seen in sun-exposed areas. Other cutaneous findings, which are not as common as those seen in previous slide, include livedo reticularis, purpura, Raynaud's changes, palmar vasculitic lesions, and even bullae. Joint manifestations in lupus are present in around 50% of patients. Oligo or polyarthritis is non-deforming and involves both large and small joints. Monoarthritis is not a usual finding, while myositis can present as proximal symmetrical muscle weakness. Lupus can affect the central, peripheral, and autonomic nervous system. Hence, the spectrum of manifestations range from simple headaches, psychosis, stroke, cranial nerve pulses, cognitive deficits, and even transverse myelitis. CNS involvement may also be aggravated by the presence of antiphospholipid antibodies. Cardiovascular involvement is not frequent. Cirrhosis is mostly asymptomatic but may be severe in some patients. Endocarditis of lupus is aseptic or aseptic, commonly affecting the mitral valve, and this is called the Liebman-Sachs endocarditis. Other reported but infrequent manifestations include acute lupus pneumonitis, alveolar hemorrhage, interstitial lung disease, and pulmonary hypertension, and these are more commonly seen among adult patients with lupus. Approximately half of children with lupus has nephritis at the onset or during the course of the disease. These patients will present with frothy or tea-colored urine, edema, anosarca in severe cases, hypertension with or without increase in serum creatinine. 80 to 90% of childhood lupus nephritis develops within the first year of diagnosis and is considered a significant cause of morbidity and mortality across all ages. The initial basic test if lupus is suspected would be CBC and urinalysis. We look for anemia, leukopenia, lymphopenia, and thrombocytopenia. While in the urine, check for proteinuria, hematuria, or CAS in the urine. SED rate is expected to be high, while serum complements are low. ANA is positive in 90 to 95%, and you may want to look for specific antibodies, including anti-double-stranded DNA, anti-Smith, others are anti-RNP, SSA, SSB, and antiphospholipid antibodies. Systemic lupus erythematosus do present in many ways. So allow me to present a couple of slides highlighting the report of the different childhood lupus cohorts across the globe. In Southeast Asia, the most common organ systems involved a diagnosis is hematological, renal, and mucocutaneous. There were some variabilities noted in the manifestations in the different countries in the region. The disease activity scores at diagnosis were found to be higher compared to the published Western cohorts, further strengthening the fact that indeed ethnicity does affect the presentation and outcome of patients. In the UK juvenile lupus cohort, they compared the presentation of different age groups and found that adolescents with lupus have higher ACR criteria with ANA and anti-double-stranded DNA positivity, prominent hematological manifestations, and low complement reflecting classical lupus. Same with the Southeast Asia data, they have high frequency of mucocutaneous, musculoskeletal, and renal with the addition of cardiorespiratory involvement. In the US, they have the CARA registry involving 70 centers, now with close to 700 patients. The mean age is 14.3 years. The cohort, as you can see, is both ethnically and racially diverse. The top 3 manifestations at onset are mucocutaneous, musculoskeletal, and renal. They had moderate disease activity at onset. In order to address the heterogeneity of the disease, lupus, classification criteria has been used to homogenize the population of patients entering a clinical research study. From the ACR to SLIC, this is the 2019 ACR Euler classification criteria of SLE. The entry criterion is the presence of ANA of at least 1:80, and if positive, then check for the presence of clinical and immunological domains which have corresponding weighted scores. In the interest of time, I will not go through each of the domains as this is readily available online. Important to note that the total score needed to diagnose a patient with lupus is 10 or more. But we have to be very cautious in using this classification criteria to patients. Let me give you 2 examples of patients referred to me because the resident thought of systemic lupus erythematosus using this classification criteria. First patient is a 14-year-old female who presented with prolonged fever for 2 months. Pericardial effusion was present, proven by 2D echo, with the presence of anemia and leukopenia on complete blood count. They suspected lupus, hence ANA was checked and it was positive at 1:80. Using the classification criteria, the patient got a score of 10. But is this lupus? Well, I said no to the resident. I told the resident push for further workups, and it turned out that that diagnosis is not lupus, but TB pericarditis. The second patient is a 10-year-old female with significant proteinuria, pleural effusion, and leukopenia. The ANA was positive at 1:160. Is this lupus? Again, using the classification criteria, you would think yes, but this patient underwent kidney biopsy and it was not lupus, but turned out to be ANCA vasculitis. Classification criteria is certainly helpful and should be used as a guide to diagnose patients, but it is also very important to look at the overall picture of the patient. Remember that there are a number of diseases, both rheumatologic and non-rheumatologic, that can mimic lupus. Another reality is that lupus patients can come to us with unusual presentations. So allow me to share with you these two cases. First is a 14-year-old female who came in with a sudden painless loss of vision on the right eye. Pertinent findings were significant loss of vision and the presence of cotton wool spots with hemorrhages on fundoscopy. She was diagnosed with retinal vasculitis. Initial diagnostics showed a normal CBC, high SED rate, normal CRP, and negative workups for liver and kidney. Chest X-ray was likewise normal. So when the patient was seen in the rheumatology clinic, further review of systems was unremarkable except for fatigue and minimal hair loss. No other abnormal PE findings. Further workup showed that she was positive for ANA at 1:640 with high titers of anti-double-stranded DNA and anti-Smith, negative for the rest of the autoantibodies. She has hypocomplementemia as well, but no antiphospholipid antibodies. Retinal vasculitis can occur in lupus, but quite rare as an initial manifestation. The prevalence of retinal involvement in lupus is around 5 to 16%. The underlying microangiopathy is due to immune complex-mediated vascular insult with occlusive consequences. The most common finding, similar to that seen in the patient, is cotton wool spots secondary to focal retinal ischemia. It may be associated with antiphospholipid antibodies, nephritis, and CNS involvement. The second patient is a 10-year-old girl who came in with progressive diffuse abdominal pain, bilious vomiting, and fever, but no diarrhea. On examination, the abdomen was distended with hypoactive bowel sounds, diffuse tenderness with muscle guarding, and scout film of the abdomen showed diffuse bowel distension with air fluid level. Abdominal CT scan showed significant bowel wall thickening with enhancement of the small and large bowel, and it was signed out as GI vasculitis. Based on the imaging findings, this patient was referred to rheumatology service. Initial workup showed that the patient has anemia, again, high SED rate, normal CRP, urinalysis showing proteinuria and hematuria. She was positive for ANA, anti-dsDNA, and anti-SSB with low C3, again, negative for antiphospholipid antibodies. Intestinal vasculitis is a rare but a serious GI manifestation of lupus, occurring in only 1 to 2%. The small bowel is the most commonly affected site. Patients present with diarrhea, bleeding, or even intestinal infarction with perforation, and it may happen during a flare or impending flare, and may also be associated with antiphospholipid antibodies. So both patients were diagnosed as lupus and treated accordingly with steroids and hydroxychloroquine. Fortunately, both responded well with good outcome. It is not easy to manage a child with lupus. Apart from the challenges mentioned in the diagnosis, there are also challenges in the management. First is controlling the disease. Second is obtaining patients' adhesion to treatment, especially for adolescents who tend to stop taking medications on their own. And finally, preventing damages induced by medications. Over the years, the outcome of patients with childhood lupus has significantly improved. The 5-year survival rate is now more than 90%, while 80 to 90% for a 10-year survival rate. The major causes of mortality remains to be infection, nephritis, CNS lupus, and pulmonary hemorrhage. Despite the advances in the information on the pathogenesis and treatment, there remains to be a number of unmet needs as shown in this diagram. A major issue is the heterogeneity of the disease. Now, could precision genomic medicine be the answer to this issue? Compared with the conventional classification of lupus patients by disease activities, histopathological features, and lab test results, maybe the integration of multi-omics data by artificial intelligence can more efficiently classify patients with lupus. With this, clinicians can select the treatment that could work best for each patient. Well, for now, we just have to focus on providing the best treatment and put in mind these special concerns. First, the psychological impact of living with a chronic disease. Second, growth retardation and changes in physical appearance due to the disease or its therapy. Third, the potential short and long-term impact of subclinical neurocognitive dysfunction that may lead to learning deficits in many of these children. And finally, the recognition and establishment of measures to prevent and or control the development of atherosclerosis. In summary, childhood SLE accounts for 10 to 20% of all SLE cases, and their striking influence in age and race in presentation and outcome of patients. The spectrum of disease can span from mild to severe with relapsing and remitting course. And finally, the heterogeneous nature of the disease remains a challenge in the diagnosis and treatment. My last take-home point is that lupus do present in many ways, and the approach to diagnosis and treatment should be individualized and tailored fit. I thank you all for your kind attention.
Thank you, dear Professor Bernal. That was amazing. I see a question in the chat box. Let's find it. How common is optic atrophy?
Optic nerve atrophy?
Yeah. How common is optic nerve atrophy?
It's not very common, similar to, I presented a while ago, similar with retinal vasculitis. It's not a very common ophthalmologic manifestations among patients with lupus, but we do see that.
Okay, thank you a lot. Dear Professor Sadeghi.
Hello, everybody.
Hello. Hello, dear Professor.
First, thank you so much. And at first, I must thank Dr. Bernal to accept our invitation to come to our meeting. And that was great presentation. I have a question about the second case that you have presented, with GI vasculitis. What brings you to check ANNA in this patient? You know, just the report of the radiological colleagues that he or she or he, I don't remember that, has GI vasculitis, or you think about other symptoms that maybe some part of SLE disorder?
Well, unfortunately for that patient, there was no other clinical manifestations which are quite specific for SLE. So, of course, when we see GI vasculitis, we think of the primary systemic vasculitis like Henoch-Schönlein purpura, or probably the other ANCA vasculitis. So that this patient was also worked up on that line, but definitely not HSP because there was no purpura. So we did the complete workup, and turned out this patient had specific antibodies for lupus and was diagnosed and treated accordingly.
Thank you so much. And the other question was that, you know, our dilemma is when the ANNA is negative, especially with this new classification criteria with the ACR. We don't know what to do. ANNA is negative, and we do have so many symptoms and signs of childhood SLE, and we don't know to start the treatment or not. What's your idea about it when the ANNA test is negative?
Well, of course, we always base on the clinical manifestations, and knowing the fact that there is at least 5% ANNA negative among lupus patients. So if you think that the clinical manifestations, including probably some lab tests in terms of CBC and urinalysis, a SED rate, which may be helpful, the complement would also be very helpful if it's quite low. You may need to check the specific autoantibodies. I've had patients with the typical manifestations of lupus, negative for ANNA, but when we check for specific autoantibodies, they're mostly positive for anti-SSA and anti-SSB. But those patients were negative for anti-double-stranded DNA. So if there's a highly suspicious if these patients were highly suspicious for lupus, and you've made sure that to rule out other differential diagnosis, particularly infection, malignancy, then I think I would go with treating this patient as SLE. If you, let's say you don't have any access for requesting for the specific autoantibodies, then you may go clinical.
Thank you so much. Again, thank you for accepting our invitation to come to our meeting. And that was very great cases that you have presented to us. Okay.
Thank you, Dr. Clayman. Thank you. Thank you. A pleasure to be here. Thank you.
Okay. Thank you so much. Okay,
Dear Professor Bernal, is it possible for you to stay with us, because the next presentation will be on lupus by Dr. Scott, but unfortunately we don't have him today live, and I can still see too many questions about lupus erythematosus. Will you stay with us, and I will ask you all the questions at the end of session?
Okay, sure, I will stay.
Thank you very much. Thank you. And for the next presentation, we will go on the great presentation which Dr. Chris Scott made for us. Unfortunately, we are unable to have him today live. Dr. Chris Scott is the head of pediatric rheumatology at Red Cross War Memorial Children's Hospital. His research seeks to understand key issues in pediatric rheumatology in South Africa and improve care for children with rheumatic disease in less resourced regions. He initiated the first training program in pediatric rheumatology at the University of Cape Town and has trained 11 graduates since 2010. He has a special interest in systematic lupus erythematosus, juvenile idiopathic arthritis, fibrodysplasia ossificans progressiva, and interferonopathies. Dr. Scott is Associate Professor of Pediatric Rheumatology at Institute of Child Health, Red Cross War Memorial Children's Hospital, and University of Cape Town, South Africa. Dear Ehlers, will you please share us?
For sure, I'm going to do.
Thank you.
Good evening. My name is Chris Scott. I'm a pediatric rheumatologist from Cape Town, and I'm really on. I hope that in the Good evening. My name is Chris Scott. I'm a pediatric rheumatologist from Cape Town, and I'm really honored and thrilled to have been invited to give a talk at your conference. I hope that in the future I'll be able to visit your beautiful country myself. My talk is entitled Lupus, which is an update for pediatricians. And I'll just be going through some of the main features that I think are changing in the world of lupus at the moment. The first thing I think is that for years, for many decades, people thought of lupus as a European disease. In fact, it was named after the European grey wolf. And so people lost sight of the fact, and there was very little research to dissuade them of this notion. But people thought that lupus was a European or a North American disease, and they found it strange that when people from further south immigrated to these countries, they developed more lupus. And I've developed a bit of an interest in lupus over the years, and of course this must go hand in hand with an interest in wolves. And I think of the world changing at the moment to take more notice of other wolves or other forms of lupus that are around, such as the African golden wolf, the Ethiopian wolf on your top right, the South African wild dog, which is actually a relative of an ancestor of the European grey wolf. But I was surprised to find that there's also an Iranian wolf called Canis lupus pallipes, which the pallipes means pale feet, which you can see on the picture on the bottom left. So there are many different phenotypes of lupus, and I believe my excellent colleague has already informed you about these. And it's not surprising that people don't really know about other forms of lupus, because there's actually very little literature reported about other forms of lupus, and it's certainly changing at the moment. And I was very impressed to read some of the literature from Iran on all the lupus patients that are there, and so and the amazing work that's been done in researching them. In Africa, we've had our own challenges trying to make people aware that people in Africa do get lupus, in fact, a lot of lupus, and that the lupus phenotypes we see are quite severe. The opposite is true for... when we talk about the mortality of lupus, there's been a definite decrease over the decades. You can see in the 1950s, the rate of mortality was 2 per 100 patient years. And by the year 2000 was reported to be much lower than 1 per 100 patient years. But one wonders if that is true for all the patients in the world, especially those patients living in under-resourced areas. We know that about 20% of people who develop lupus when they're still young, and that the relative gender difference increases with age, in that children who present with lupus are more likely to be boys than they are when they develop lupus at an older age. Of course, this doesn't mean that the female preponderance for developing lupus is lost totally. It certainly is at least 2.3 to 1 in children under 10 years. But puberty does seem to play a role in predisposing women to developing SLE. We know as well that the mortality of lupus in children is higher than that in adults. If one looks at this curve, the mortality decreases as one ages, as the age of onset of lupus increases. And we know that in Africa, these cohorts are not very well described, and in other parts of the world. This is a photograph from my colleague, Dr. Falea in Nigeria, who told me about her cohort of patients with SLE. And you can see that more than half the patients in her cohort were either dead or had defaulted treatment. I was interested to read a number of excellent case reports and case series from your own country. And in summary, I noted that most authors felt that the major manifestations of lupus were similar in your cohorts as they are to other countries in your region and with similar climates, and that renal and central nervous system disease drove the mortality in these areas. This was shown specifically in this large paper of over 180 children with lupus and 394 adults with lupus, showing the effect of having lupus nephritis in children on this Kaplan-Meier survival curve, showing how that decreases the likelihood of survival over time. It was also shown in this paper from Iran that seizures, nephritis, and proteinuria were major predictors of death in children, which is different to adults, where seizures, pericarditis, and hematuria predicted death. This is just another summary of a very large study of patients with lupus from Iran, 2,280 patients, showing the generally high levels of renal involvement and neuropsychiatric involvement in this lupus cohort, especially compared to cohorts from Europe. I'd like to spend a moment just talking about the classification criteria of lupus, and probably the most important thing to say at this point is that classification criteria should not be used as diagnostic criteria. Most of us at medical school would have learned about I think it's the 1992 or 1997 ACR criteria that demanded that one fulfilled 4 of one of these criteria: malar rash, a discoid rash, photosensitivity, oral ulcers, arthritis, pericarditis or pleuritis, a renal disorder, neurological disorder, hematological disorder, immunological disorder, or positive ANA. And if one didn't fulfill all 4 of these criteria, lupus couldn't be classified for study purposes. And this led people with the problem that someone with a positive ANA and a renal biopsy that looked exactly like lupus technically couldn't be enrolled in a study because they wouldn't classify as having had lupus. Following on that, the SLIC criteria were developed. And these included 17 criteria, and one needed 4 out of the 17 criteria. Of at least 1 needed to be clinical and 1 needed to be immunological or a biopsy-proven renal lupus nephritis. So in this scenario, one could be ANA positive and have lupus on a biopsy and then be diagnosed as having lupus. These criteria were again not perfect, and further work was done, and the latest set of criteria we have are the ACR-EULAR classification criteria, which are slightly more complex, but have as an entry criteria an ANA titer of at least 1 in 80 on HEP2 cells, therefore not an ELISA ANA, but one that is done with immunofluorescence on HEP2 cells. And if absent, it's according to these criteria not possible to classify as SLE. Then there are additive criteria which have different scores. One can see their constitutional symptoms such as fever or hematological complaints such as autoimmune hemolysis each have a different score. Something like seizures or renal biopsy with class 3 or 4 lupus nephritis score very high scores, and one needs only to have an ANA that's positive and at least a score of 10 to be able to be classified as having lupus. Again, these are not diagnostic criteria, they're classification criteria, and I'll mention that a little bit later again. But these appear to be the most sensitive and specific criteria that we've had to date, and are currently being validated in children. And so these are the kinds of children we see with SLE. This girl didn't need a whole set of classification criteria to be diagnosed as lupus. The rash is very obvious and very typical and very severe. And this poor girl developed severe pleuritis and pericarditis and renal failure, and nothing we did over all the years of treating her could really bring these symptoms into abeyance. We had given her every immunosuppressant that we knew of, and eventually she needed a kidney transplant, and despite this, has demised. So there really is still a lot of work to be done in treating lupus. But treating lupus is more than just obviously giving a therapy. We do still lack really potent and effective therapies for lupus, but there are other things that should be considered in the management of lupus that are not as simple as giving therapy. The SHARE initiative, which although it is based in Europe, collaborates with many centers across the world, including Iran, is called the Single Hub and Access Point for Pediatric Rheumatology. I've come up with an excellent set of recommendations for the management of lupus, and these include statements such as the one that I've highlighted here, that in the presence of a positive ANA combined with at least 2 clinical SLIC criteria, or the presence of a positive ANA combined with at least 1 clinical and 1 immunological SLIC criteria, a patient should be referred to a pediatric rheumatologist. This sort of refers to the fact that one shouldn't be using these criteria as diagnostic criteria, but rather as classification criteria. And this is helpful in getting children into care earlier. Another important point is that in patients with childhood SLE, especially in the very young patients, hereditary complement deficiencies should be considered. And this is something that's obviously very different to adult lupus. In terms of the monitoring and management of SLE, there are several important recommendations, but I'd like to draw your attention to this one, which is that all children with childhood lupus should have disease activity assessed regularly using a standardized disease activity measure, such as a SLEDAI-2K or a BILAG 2004. Now, these lupus measurement tools offer one the ability to measure how the lupus is doing, what the level of disease activity is, and enables one to identify when a patient is flaring. This is really important in trying to manage a patient and in trying to not only increase their treatment, but also decrease their treatment so that they don't develop side effects from immunosuppression. The SLEDI-2K is widely used, probably slightly more so than the BILAG criteria, because the BILAG criteria are extremely, are a little bit more technically difficult to do, but the SLEDI criteria and scoring are very straightforward, and you see them here. Seizures, psychosis, organic brain syndrome, lupus, headache, vasculitis, and so on all get 8 points, and there's a descriptor for each of them. Vasculitis, arthritis, myositis, etc. gets 4 points, and something like leukopenia or thrombocytopenia or fever would get 1 point. And then based on the score, one can then track and follow a patient and decide on remission, improvement on therapy, or a flare. And probably the most important treatment recommendation is that all children with lupus should be on hydroxychloroquine routinely. In the studies that I read from Iran, this was already the case, so I'm sure I'm preaching to the converted. And in all of those studies, by far the majority, if not all the children, were already on hydroxychloroquine, but there also seemed to be a large need for steroids, and most children were treated with cyclophosphamide rather than MMF, and I'm sure that's probably because of a financial consideration. The SHARE guidelines also give good guidelines on how to manage lupus nephritis, and I won't go through all of this, but it's really just a pointer that this algorithm is out there and is easily accessible and very useful if one is dealing with lupus nephritis. One of the questions that remains unanswered, though, and it brings me back to the Iranian wolf and the South African wild dog, is whether all children with lupus can be treated in the same way and whether there are different phenotypes of lupus across the world. And I believe my colleague will have mentioned this. But we also know that children respond to treatment differently based on their race or ethnicity, and this, or at least adults do. And this was very clear in the ARM study, where black patients, African American patients, responded better to mycophenolate mofetil than to cyclophosphamide. An important new paper that has just been released is an international consensus for the dosing of corticosteroids in childhood onset lupus with proliferative lupus nephritis. Now, this paper tries to offer clinicians some kind of guideline on how and when to wean steroids, when to increase it. And it was based on the contributions of a number of clinical experts from across the world, and reflects really the experience in these clinicians of managing lupus over a long period of time. The ultimate aim is always to try and keep steroids as low as possible and to use DMARDs to enable this. This paper should offer some guidance to people when they're unsure of how and when to wean steroids. Another important venture is the concept that of low disease activity in lupus. Several criteria have been developed for adults in a treat-to-target method of treatment, and we are moving in that direction with lupus as well. Eve Smith and Michael Beresford are currently leading a big group to try and develop treat-to-target guidelines for lupus in children, and part of that is deciding on what is low disease activity, etc. And this is a space to watch for the future. Another thing that's currently happening is based on a study that we did called JAMLess Arthritis Management in Less Resourced Countries. This brought together experts from all over the world to try and work out guidance for treating juvenile idiopathic arthritis. We started with a needs assessment from many low-resourced countries to try and identify the needs of children living with JIA and the perceived need from clinicians about what they needed to be able to treat JIA. We fed these questions into a literature search. We came out with 90 initial statements. We worked on these statements and finally could research them, debate them, and through Delphi technique settle on a final set of recommendations comprising 34 statements which have been published and are available. Professor Amita Agrawal from India, an excellent lupus clinician with extensive experience in managing both childhood and adult lupus, is currently leading such an effort for lupus, the lupus guidelines in less resourced countries. Just the last word on the future. It's clear that some patients with lupus most patients with lupus have a very strong interferon score, as these gene expression slides show, where interferon genes are upregulated in patients with lupus and gets higher as their disease activity measured by SLEDAI gets higher, much higher so than in other people with arthritis or in healthy controls. And these lupus scores, these interferon scores, are helping people to decide on therapy, and also offering us new pathways of care for lupus in terms of suppressing the interferon pathway. It's also interesting, though, that a recent study, quite recently published, showed that there are actually not just interferon-based pathways or genetic signatures for lupus, but also signatures that identify plasma cells and neutrophil pathways. And so there might actually be 4 different kinds, or 3 main different kinds of lupus: interferon-related, neutrophil-related, and plasma cell-related sort of interferon or gene expression signatures. Gene expression signatures that identify different groups of patients with lupus that might respond differently to therapy, and brings us closer to the concept of personalized medicine. All of this medicine is happening right now, and it's a field of rapid development. And I'm sure that in the future we will be stratifying our patients in this way. It's important that we start including patients from our regions, Africa and Iran, for instance, into these studies, so that we can develop therapies that are appropriate for the patients we treat. With that, I'd like to thank you and thank the organizers for inviting me. Again, it was a great honor. And if anyone has any questions, please feel free to ask them or mail me at this email address. Thank you very much.
Okay, let's continue. Unfortunately, we didn't have the chance to have Dr. Scott today with us, but let's make a conclusion on our topic, systematic lupus erythematosus. Dear Dr. Bernal and dear Dr. Saderi, I'm here with you.
Okay. Dr. Kahramanlu, what was the question?
Okay, the first question, dear Professor Bernal, in children, do we depend on minor or major criteria like adults in order to diagnosis of systematic lupus erythematosus or not?
In terms of classification criteria, we share the same, meaning whether for children or for adults, we use the same classification criteria as mentioned in the presentation. So there's no separate criteria for childhood SLE.
Okay, and the next one, what was your experience with rituximab in lupus nephritis?
I've used rituximab for a few patients, particularly for those who failed the conventional treatment. For patients with lupus nephritis who failed both cyclophosphamide and mycophenolate mofetil with persistent nephritis. In terms of response to treatment, particularly rituximab, it's more of a 50-50. 50% of my patients responded to the combination of either rituximab plus cyclophosphamide or rituximab plus mycophenolate mofetil. Unfortunately, 50%, despite the addition of rituximab, the nephritis persisted on and the creatinine went up.
Okay, and the next one, what's your opinion on recurrent pericardial effusion with bilateral effusion in lupus?
Well, it can definitely happen. Lupus can flare anytime, so meaning the manifestations can definitely recur. But in such situations, one is you have to assess whether the recurrence of the effusions are truly secondary to lupus, meaning we have to open up the differential diagnosis to other causes, particularly infection, like TB. TB can also cause pericarditis. TB can cause pleural effusion, particularly if the patient is on immunosuppressive treatment. But definitely it can happen. Then if you are pretty sure that the recurrence of the effusions is due to an active lupus, then you may have to review your treatment and may need to change your management.
And what's your experience about using tofacitinib in treatment of cardiac lupus erythematosus?
I haven't used tofacitinib in any of my patients with lupus. No indication yet for tofacitinib in lupus, as far as I know.
And another question on rituximab. What's your opinion of using rituximab in this COVID-19 pandemic?
Oh, rituximab.
Yeah, using I think they mean using rituximab in lupus and while I don't know, while it's the pandemic of COVID-19.
Well, for severe COVID, what we use here in our country is tocilizumab. I haven't used rituximab for patients referred to me with severe COVID. I think even adult infectious disease specialists and adult rheumatologists here, they use tocilizumab. An alternative would be baricitinib. We haven't used rituximab for severe COVID. Even for Miss C, we haven't used rituximab as well.
She's asking.
Dr. Rahman, just a second. You know, the exact meaning of the question was that what is the safety of using rituximab in SLE patients during this pandemic of COVID-19? You know,
sorry.
Because yes, because there is a great concern about immune deficiency after using rituximab and making the patient susceptible to the COVID-19. So that was the core of the question, and I think we must try it in critical situation, because sometimes we are losing the patient and we have to use these kind of drugs in critical situation. So we must judge the patient, every patient for himself or herself. If all the symptoms and signs shows that the patient doesn't have COVID-19 infection, so we can use it easily. But after using it, we have to concern about getting the infection. So we must tell the patient that to be more careful about not getting the infection after using rituximab. So that was the question. Sorry for interrupting you.
Thank you for the clarification, Dr. Pullman.
Thank you so much.
And the next question. Would you recommend ruling out primary hypocomplementemia in patients with lupus, or only in certain cases?
Well, it's not routine to check for primary hypocomplementemia, or let's say complement deficiency, in all patients with lupus, but probably I would look into that in patients with lupus developing it very early on in life, particularly for those less than 5 years of age. Meaning early onset lupus, you have to at least investigate for the presence of complement deficiency. But for the typical age group, let's say an adolescent patient presenting with SLE, of course, hypocomplementemia is expected, but it's not routine for us to check for complement deficiency.
Yes, for this question, I do agree with Dr. Christine, because that was a great answer for this question. Yes, I do agree with Dr. Christine.
Thank you.
Thank you so much, dear Dr. Christine and dear Professor Sadeghi, for making this good, how can I say, educational speech. Thank you so much. And if you agree, we will go on, dear Professor Hans Degraaf.
Again, thank you, Dr. Christine, to accept our invitation. And that was a short but comprehensive explanation about childhood systemic lupus erythematosus. Thank you so much. Let's go to the next speaker.
I'm sure we're going to have an amazing Dear Professor Degraaf, let me introduce you.
Thank you. Can you hear me? Can you see my slide?
Yeah.
Yes.
Please let me 1 minute to introduce you. Sorry.
Okay.
Sorry for interrupting you. Dr. Degraaf was previously worked at Foundation Trust of National Health Service and Wellcome Trust of National Institute for Health Research at Southampton University and Hospital, United Kingdom. Now he's working at Elizabeth II Cities Hospital, Tilburg, the Netherlands. His clinical research consists of co-authoring 27 peer-reviewed articles and participating in 2 clinical trials in the past 15 years. Thank you so much, dear Professor Degraaf, for joining us, for accepting our invitation. I know you have prepared an amazing case for us to share your knowledge with us. Thank you.
Thank you. Thank you very much. Can you see my slides? Not yet. Ooh.
That's okay. Thank you. That's okay.
Yeah. Can you see it now?
Now, yes, I have your slide completely full screen, and thank you. It's perfect. Let's start.
It's perfect.
Let's
Okay.
get started.
I'll just start. Okay. So thank you very much for inviting me to do this talk. It's a real pleasure. So I'm Hans Degraaf. I'm a pediatric rheumatologist from Southampton, where I worked together with Dr. Leahy. And we had a very nice collaboration with Professor Sadeghi in the Tehran University of Medical Science. I recently moved to the Netherlands, so now our little network is even a little bit more international, and I hope it will continue like this. So my disclosures is that I have a European grant for work on pertussis, so nothing related to this to this talk. And what I would like to do is, so my talk is a little bit different from the other talks. I was thinking, as a general pediatrician, what do you want to hear from me? So I'm going to walk you through an interesting case, which offers a few take-home messages. I think very often we have talks about a certain disease with symptoms and classifications like lupus, but it's quite complicated, and the patient never presents like that. Never presents with a book story just from the book. So and I think that's why the general pediatrician is very, very important in this. As a general pediatrician, you see a child with the first initial symptoms. It's often not the complete picture. Yeah, but you have to make decisions on that. You have to ask for help. You can ask a specialist for help, but there's very often just an organ-specific specialty, like neurology or respiratory, and sometimes it's just more than one organ system, and you need someone with an overview, and I think that's where the general pediatrician is super important. But you also have the pediatric rheumatology to help you, because very often it gets a little bit more complicated, and very often it's immune related. And that's where the pediatric rheumatology comes in. So what I would like to give to you as a take-home message is that the general pediatrician needs to communicate very well with all the other subspecialties and work together with the pediatric rheumatologist to provide the best available care. So the other take-home message I want to give you is when is it not what you expect? So we very often focus on the initial symptoms, on the tests that we need to do, how do we get to a diagnosis, but we also know that it just doesn't happen like that in clinic. Sometimes you make a plan, you think this is probably the diagnosis, but I'm not completely sure. Let's just start treatment and keep a very close eye. Admit the kid, see what it's doing, evaluate the treatment effect, and then something happens that it's not responding like you want it. But when is that the case? You don't expect this guy to drink a beer during Corona with his buddies, but yeah, keep an eye on that. So that's sort of the case that I would like to present to you. It starts with the case background. It's a girl who presents to the general pediatrician with very common symptoms, I think. I think most general pediatricians see this very often. Some eczema, bronchial hyperactivity at the age of 3, then recurrent upper respiratory tract infections. Also not very exciting. We see this all the time in the general pediatric outpatient clinic. Microcytic anemia, because it was a little bit too much. She had a full immunological screening with some suboptimal responses, but responded good to the booster, so it was otherwise fine, with nothing to worry. The girl was growing, she was otherwise doing really well. Urinary tract infections, also not that surprising, I think. But then at the age of 9, she presents to the ophthalmology department with 2 weeks vision loss, and she was seeing dark spots. The vision in her left eye was then 20% only, and the right eye was completely normal. And on fundoscopy, there was some papilledema. So this is unusual. Yeah. So now we start thinking there is something wrong. So what is this? So could be an optic neuritis. It's not something you see every day. I think I don't see an optic neuritis every day. So I thought I'd give you a little bit of an update on that. So optic neuritis in children is associated with multiple sclerosis. There is it's bilateral in 10% and more common in the age of 12 to 15 years. We think it's immune mediated, but we don't really know. Yeah, so we can associate it with some antibodies like the aquaporin 4 or the myelin oligodendrocyte. But how that works exactly, we don't really know. Yeah, so unclear. You do see deficits in the vision, in the visual field, the contrast and color, and the workup is an MRI and a lumbar puncture. So why do we do that? Well, if you look at causes of optic neuritis, it can be infectious, post-infectious, ischemic, multiple sclerosis, like I said, and then some autoimmune problems. We always think about lupus, but yeah, you just heard some very interesting talks about lupus, and it's not always an easy diagnosis to make. And in this child, I think with a negative ANA and otherwise no other features, there was no reason to think about lupus at that moment. Can be paraneoplastic, and then I think with a kid like that, you should also think, is it really an optic neuritis, or is there something else pressing on that nerve? So in her case, an MRI was done of her head, and no abnormalities were found. She had light punction, showed no abnormalities, all fine, negative antibodies, concluding, okay, it must be an optic neuritis. We can't find a cause. Let's just treat it like that. Yeah, and this is how they treated it, and they used to treat it in the ophthalmology or the neurology department. Is 3 days with methylprednisolone IV, and that stopped. Yeah, so I think in rheumatology we used to give them a methylpred pulse and then wean it off or take it on a little bit longer. But this is how they're treating it in the neurology. And 3 weeks later, she was followed up and she was fine. There was still visual loss, but otherwise she was completely fine. Then a year later, she presented again at the general pediatrician. This time she had another otitis media, like she had many before. Was given azithromycin, but no improvement. And she was feverish and not feeling well. High fever of 39.7 with a high heart frequency, but otherwise no real clues on physical examination. But then when we did blood, so chest X-ray was normal. When we did bloods, she had neutropenia, quite deep neutropenia of 0.02. And a high CRP. So suddenly we're having a 10-year-old kid with no clear focus, but fever and deep neutropenia. So cultures were taken and started on Kefta and vancomycin. And we, as pediatricians, I think we always get nervous when we see a neutropenia. These kids are at risk, isn't it? So I think there's a few things to learn from that as well. The questions you ask yourself in a neutropenia: is the child really at risk for an infection? And what's the cause of the neutropenia? Yeah, and I think it's good to realize that if you take a blood sample, what you measure is only 3% of the total neutrophils in your body. Yeah, so the other ones are somewhere in the tissue, in your bone marrow. There's a big reserve. So if it is just in the blood, it's a completely different story. And as pediatricians, we're very often confronted with neutropenia because of chemotherapy, and then of course it's a completely different story, because then you got a full depletion of your bone marrow. So if you look at the risk of infection in neutropenia, there's quite some well, less malignant or less at risk neutropenias that don't give that much infection, like a chronic benign neutropenia, or an autoimmune neutropenia, antibody mediated. Yeah, but I think as pediatricians, we're very much more on the high risk side of this table. But there is a lot of children, especially if they present out of the blue, that are not that much at risk from neutropenia, all depending on the bone marrow depletion. So that's one of the things I just want to give to you. So we did lots of investigations, of course, because we were worried about this child, and we were wondering what is the cause of this neutropenia. So what you can see is all kinds of tests that we did. She had a slightly low IgA, not very much to say about, I think. And then what we did is we sent the blood for granulocyte antibodies, and it came back after a week saying that there is some weak antipositive anti-FcR3 IgM, but IgG was negative. And that kind of influences the story. So it's good to remember that initially we had a positive test, and later we had a negative test. We did some immunophenotyping, and it showed no signs of leukemia. Bone marrow was not done at that moment. And this is basically how it went. So on the top, you can see the fever pattern. Started antibiotics, fever came down. We were quite happy with that. We were waiting for the results, thinking this might be an autoimmune neutropenia. And in the meantime, the neutrophils were going up a little bit, as you can see in the lower part of this slide. So we were happy, Kit was happy, and the plan was to continue with the antibiotics. Working diagnosis, autoimmune neutropenia, plan to stop the antibiotics when there wasn't any fever for 48 hours, and then go home. So on day 6, she was ready to go home, but then she spiked fever again. And this is exactly how it looked. Clinically, she was completely well all the time. So 7 days after admission, all the blood cultures were still negative, but she spiked fever again. So we thought, well, maybe it's the antibiotics. Let's switch it to meropenem and start covering some fungal infection as well with itraconazole. And clinically, she was well. She was chatting. She was less well when she had a fever, but no focal symptoms. And this is basically what happened over time. So you can see this long period that the fever was sort of okay. Then she spiked fever every once in a while, but not really controlled. And then at some point, you can see all those spikes going up and down. And that's where she started to have fever again. And this triggered some more evaluations. As we couldn't find a PET scan, we were worried, is this some kind of abscess? Are we missing anything? The abdominal ultrasound was fine, cardiac was fine, chest x-ray was fine. So we decided to do a PET scan. And I think this is interesting, because I think in the clinics that I've worked, we always had discussions about this. If you don't know, maybe you can do a PET scan. It sounds very attractive. It will give you really nice pictures of your whole body, and the uptake will show you where the infection is. In this case, there was enhanced signal in the bone marrow, an enlarged spleen, but no clear focus. And then if you look at literature, there is quite a lot of literature about PET scan in fever of unknown origin. But if you look at the diagnosis they come up with, I can't help thinking, is this really the only way to come to this diagnosis? I mean, should we not do bone marrow or do more other investigations? And is the PET really helping? I am not convinced, but I'll leave that up to you if you have the availability to do a PET scan in the first place, because it's not very widely available. So as we couldn't find anything, and we wanted to do a bone marrow, but for that she needed to go to an academic hospital 50 kilometers away from here. She was transferred to an academic hospital, clinically still fine. They did a bone marrow the next day, and it showed no signs of malignancy. It was completely normal. But then her ferritin went up to 1,000. Not super impressive, but definitely too high. And after lots of discussion with the hematologist, the oncologist, the rheumatologist, the general pediatrician, it was decided that they started on methylprednisolone. All the investigations were done. It was more like a pragmatic choice. And then the fever stopped, and clinically she felt better after 2 days. But then things go wrong, and I think the fever starts again. She went into cardiac failure, respiratory failure, was admitted at the PICU with a very high lactate, no cause found, then was prepared to go for ECMO, and while doing that she had ventricular fibrillation and passed away. So suddenly it went very, very quick. Very unfortunate story, and very sad. And 2 days before she passed away, we got the results back from the whole exome sequencing, showing a gene variation in the ADA2 gene consistent with the deficiency of those. So basically that seals the diagnosis. It was not very comforting to find this diagnosis when it was already too late, I think. And let me just tell you a little bit about this. I don't think as a general pediatrician you have to know anything about this, but just so you know that it exists, and it kind of shows a little bit that autoimmunity kind of can explain everything, and you have these weird, very rare conditions. So DADA2 is a condition that's described since 2014. It's very rare, and it can give systemic inflammation and vasculitis, early onset stroke. I think that's one of the triggers that we do look for it. It can also cause cytopenias and immune deficiency. And how does it work? So normally adenosine is transferred into inosine with ADA1. We know that one. It's an intracellular enzyme that if you don't have it, you present as a severe combined immune deficiency. So that one was known already for quite a long time. But if it's an extracellular enzyme that's missing the ADA2, you get this rare vasculitis and bone marrow depletion. And this is it looks like there's a sort of a spectrum. So on one side of the spectrum, there's the vasculitis, and on the other side, there's the bone marrow failure and the red cell aplasia. And it all depends a little bit on how much ADA2 enzyme activity is remaining, and that is related to the kind of deletion you have. So they present with medium to small vessel vasculitis, a bit like PAN and stroke, like I already said. You can have skin abnormalities or joint and muscle abnormalities. Or the other side of the spectrum, you can have bone marrow failure. Systemic inflammation, immune deficiency is common. And some of them present very early, 25% before the age of 1. But the mean is still 5 to 7 years, and how that exactly works, I couldn't really find it. Yeah, so the skin lesions are like pen-like vasculitis of the skin or livido kind of structures. You can have strokes, like on the picture E. But as you can see, this kind of enzyme deficiency can give so many different symptoms that it just doesn't cover one subspecialty. It doesn't cover just the hematology. It's not just the cardiologist. It's not just infectious disease. You need, again, a general pediatrician to be involved and keep each other talking and work together. The treatment for ADA2 depends a little bit on what kind of presentation you have. So vasculitis sometimes responds to TNF inhibitors, but not always. And if for bone marrow failure, basically the only thing that sometimes works is an hematopoietic cell transplantation, but even then the prognosis is bad. The 50% mortality, and for the vasculitis, it's 8% mortality. So it's a really bad diagnosis. And looking back at this case, I think it was very, very sad. And all the time you keep thinking is, when did it go wrong? Did we miss anything? Were there any clues that we could have picked up that showed it was a rheumatological disease, or it was this kind of rare deficiency? But I don't think it would have changed anything. As the take-home message, I think, as a general pediatrician, if you have a patient with 2 super rare events, neurology, cardiology, infectious disease, anything, if there's 2 super rare events, they are related until proven otherwise. I think that's one of the things that taught me, that I learned from this case. Neutropenia doesn't always mean high risk of infection, but it can do. So you will cover it, but you have to keep thinking about it. If the patient doesn't respond the way you expect, you have to think again, and you have to rethink your diagnosis, which is a skill that general pediatricians are very good at, and I think we should all keep doing that again. And this case shows that as well. And everything is autoimmune. It's not really true. Not everything is autoimmune, but there is a lot of things that are autoimmune. So as a general pediatrician, I think, talk to your pediatric rheumatologist, just pick his or her brain and see if they can help and get a diagnosis that's overarching. More research is needed. That's always the thing, isn't it? So thank you very much for your attention. I hope you learned something from this sad but interesting case. And if you have any questions, please ask or email me. Thank you.
Thank you, dear Professor Degraaf. That was really educational, and I got really excited. It was really exciting case. Thank you so much for your effort, for joining us, and for our invitation acceptance. Thank you. Dear Professor Sadeghi, I'm here with you.
Okay, hello again, and hello, Hans. It's good to see you again, and it's our great honor to having you here. That was a very interesting case, and also difficult case. At first, I didn't think about the other 2 deficiency. That was because most of the time when there is some neurological symptoms, especially in young children, we think about the other 2 disease. But your patient or your case hadn't no neurological symptoms or signs at the time of the diagnosis or before the time of the diagnosis, except optic neuritis, and that was interesting for us. And do you think about any reason about high titer of the IgA? You know, because I could not find any reason for high titer of IgA in your patient. What could be related to this positive test for a high titer of IgA?
I don't know, to be honest, and I think it was a very tricky presentation with only 1 cell line that was knocked out, and the antibody responses and the lower IgA, it didn't fit together. Even retrospectively, there are still things you can't really explain, I think, and I think it just shows that this data too has such a spectrum of presentation, and it's still rare. So I think it is good to keep presenting and sharing this information, because I think we're not on top of it yet.
Yes, yes. You know, we have some reports from Iran about the other 2 patients, especially by Professor Ziai, our head of ward. And most of the time, these patients had neurological symptoms. And plus some kind of symptoms like Pond disease, polyarthritis nodosa. but this time your patient had had completely different presentation of the disease. And without any genetic test, I mean whole exome sequencing, we couldn't diagnose the underlying disease for this patient. So we have some comments here. Please, Dr. Kahramanlu, you can talk about or you can read them. And again, thank you, Hans, for your great presentation.
Thank you.
Thank you, dear Professor Degraaf. Suparna Guha asking, what was your mind when you ordered the whole exome sequencing? She or he says, I have a lupus kid with unexplained optic neuritis, all antibodies negative. Should we think of the other two?
I think it's a very good question. So the reason why the whole exome sequencing was ordered is because we had this ongoing worries about her immune system with the recurrent infections, and then a neutropenia. So what we ordered was a whole exome sequencing, especially looking for primary immune deficiencies. Yeah, but and then this came out. So we didn't really think about DADA2 at that moment. Then the next question, I have a lupus kid with unexplained optic neuritis, all antibodies negative. I think lupus without any antibodies is something you should keep thinking about, isn't it? This is one of those things that lupus is like a jigsaw of all kinds of symptoms, but most of the time, let me put it carefully, with at least a positive ANA. I think there will still be there will still be a lot of antibody negative optic neuritis. Yeah, at least 50% is what the literature says. So it's not that you have to think about it with every optic neuritis, and I don't think you should do genetic testing on all of them, although there are not so many. I think if there's anything else, like this kid also had this ongoing immune problems with repeated infections, you got an extra argument to do it. But I completely understand if you don't order a whole exome sequencing on every optic neuritis.
I can add to the Hans' explanation two things. First, when you are not sure about the diagnosis of the patient, you can use the genetic test for the exact diagnosis. But sometimes it's not good, and you don't get good results about the genetic tests, and maybe you are more confused because the genetics test has different responses, and and different results, and you don't know how to what we can say, how to choose between this kind of mutation, and which one of these mutation could explain about the exact diagnosis of your patient. This is the first comment that I have, and the second about the Hans' statements, and that was a little bit I can say terrifying, not terrifying. That was a little bit horrible for me, because he stated that whenever you have doubt about your diagnosis, you can consult with the pediatric rheumatologist, and that was difficult. In every case. Okay, thank you. Okay, Dr. Kahramanlu, you can continue.
Another comment about the patient with lupus erythematosus. Even if his or her anti-NMO and anti-MOG antibodies are negative, we shouldn't think about the two or not.
Okay,
yeah,
okay.
Same answer.
Just a minute, Dr. Kahramanlu. These messages
related to the previous
message.
Yes, related
yes.
to the previous patient.
So the patient has the exact diagnosis of the lupus, but with negative results for anti-NMO and anti-MOG antibody. You know, I think the patient has ANA positivity and also has positivity for the other antibody. Okay, Hans, do you have any extra idea, or do you have any additional idea about
No, the only thing is sometimes antiphospholipid syndrome can complicate the lupus, and you can have that as a sort of optic neuritis as well. There's maybe something to look for, but otherwise I'm afraid that the optic neuritis is very often not explained. Upla negative, already tested. Yeah, I can see that.
Okay.
Nothing to add, sorry.
Okay. Oh, okay. At the end, you can consult with the pediatric rheumatology. That's a difficult case. Yes. This is the great answer for this question.
Exactly.
Yes.
Thank you.
Again,
Okay.
so many thanks, dear Professor Degraaf, for accepting our invitation and being here with us. Thank you so much. Dear participants, please do not forget to log in with your full name in English in order to receive your certificate of attendance. Please do not forget to register on our web application and choose your session to receive the certificate. Please ask all your questions in the chat box. I will do my best to ask your questions from our dear lecturers. And let's go on with the next presentation by dear Professor Alice Leahy. Dr. Alice Leahy is a pediatric rheumatologist. She is leading the development of appropriate child-focused rheumatology service at University Hospital Southampton Foundation Trust. Dr. Leahy provides a local and regional service for children with chronic arthritis and other autoimmune, inflammatory, and musculoskeletal disorders. She also leads a regional pediatric rheumatology network to try to ensure that children receive an optimum specialist service across Wessex and the South Coast. Unfortunately, right now, we don't have dear Professor Leahy with us, but she will join us in the Q&A session, and I will ask all your questions at the end of session from dear Professor Leahy. Dear Aylar, will you please play the backup video?
Yes, for sure.
Hi, and thank you very much to the organisers of this conference for inviting me to speak today. I'm going to be talking about Ehlers-Danlos syndrome and a little bit also about the overlapping topic of joint hypermobility. I have no conflict of interest to declare. So why have I chosen Ehlers-Danlos to talk about? Well, partly because the classification of this group of conditions has been updated in the last few years, and the diagnostic criteria as well. But also because in the UK, certainly, there's still some controversy about whether hypermobility type Ehlers-Danlos syndrome is a discrete entity and whether it should still be included. And thirdly, because in the UK, we've had something of an epidemic of hypermobility type Ehlers-Danlos, and this is usually self-diagnosed and is causing us all sorts of problems, which you will soon hear about. These children will present to rheumatology clinicians because of the associated potential for MSK symptoms. So what is EDS? Well, it's a heterogeneous group of heritable connective tissue disorders characterized by, amongst other things, joint hypermobility, skin hyperextensibility, and tissue fragility. And we'll describe those in some detail in a bit. And these are due to alterations in fibrillar collagen genes or genes encoding for collagen modifiers. So to the recent-ish update of the classification of EDS, so Francesca Malfay et al. In 2017 published a paper with the updated classification. So this took the place of the old Villefranche system, which had 6 subtypes of EDS, each having a Roman number as a descriptor. There are now 13 subtypes in the newer classification, in line with recent genetic developments. So controversially, as far as we're concerned in the UK, hypermobility EDS is still in this classification, despite a lack of consensus amongst rheumatologists and geneticists as to whether it should be in there, whether it is an actual condition, given the lack of molecular backup. And there were also some concerns around who was on and who was not on the panel that devised the new classifications. So the paper, this whole project was sponsored by these patient groups, and certainly in the UK we do have some very vocal and very opinionated patient groups. And one of the themes of theirs is that it's strongly, they're feeling strongly that hypermobility type EDS is a definite discrete condition and should be included in this classification. Of concern also, there was no pediatric rheumatologist on the panel, and there was quite a heavy input from these private specialists who deal only in joint hypermobility and related forms of EDS, and we were slightly concerned about the fact that they were outside of the NHS. So this is just a look at the newer classification. So as you can see, there are 13 subtypes. We will be focusing on number 1, classical EDS, number 4, vascular EDS, and number 5, so-called hypermobile EDS. And as you can see from this table, hypermobile EDS is the only one of the 13 with no known genetic mutation and no known abnormal protein that has been discovered. So other new things in the paper, well, the nomenclature, as I said, has changed. So they used to be given numbers, types 1, 2, 3, etc. But now, more usefully, they have descriptive names, which is certainly helpful for the clinician and the patient, I think. So let's start with classical Ehlers-Danlos syndrome. The clinical criteria, which should lead you to seeking molecular confirmation, are the two major criteria. One is the skin, and 2 is around the joint hypermobility, and we'll look at those in some detail. The recommendation is that these clinical findings are backed up with confirmatory molecular testing. So yeah, skin hyperextensibility, etc. And then the minor criteria, which are mainly around the tissue fragility, the appearance and feel of the skin, but also the consequences of the joint hypermobility. So what does hyperextensible skin look like? Well, I think you'll all agree that that is very stretchy looking skin. Many people think they have stretchy skin, but actually the criteria are quite strict. There are 5 sites that need to be looked at, and you need to have positivity in at least 3 out of 5 of those sites. So the volar surface of the forearm and the back of the hand, in both those sites, you need to have more than 1.5 centimeters of stretch when you pick up both the cutaneous and the subcutaneous layers. The other 3 sites are the neck, the knee, and the forearm, where you need to be able to pick up more than 3 centimeters. Let's have a look at some of these atrophic scars. So I think you can see the thin, papery, atrophic looking scars. Another feature of these scars, as you can see from this image, is that the scar is wider than the original incision. So here we're talking about a surgical incision. They need to be seen in several sites and not be related to repeated trauma or infection. So with these clinical findings and the joint hypermobility, which we will go into in more detail, you would need to proceed to confirmatory diagnostic testing. So for this, we would use next generation sequencing. And so most geneticists will start with a targeted panel looking for a heterozygous mutation in one of the genes encoding type 5 collagen, so COL5A1 and COL5A2. If nothing is found, then they can go on to do CNV or copy number variant, which is a detection strategy identifying large deletions or duplications, or failing that, whole exome sequencing or whole genome sequencing can be used. And where genetic testing is unavailable, then an alternative would be a skin biopsy, where you would expect to see these typical collagen flowers, as they're described, on electron microscopy. So moving on to vascular type Ehlers-Danlos, which is clearly a very important diagnosis to make. It is a very rare condition, but because of the potentially catastrophic sequelae, then it's important not to be missed. These children do not, however, tend to present to rheumatology clinics because joint hypermobility, which is usually limited to the fingers, does not tend to be a predominant issue. So they may have thin see-through skin. There's history of ruptures or perforations in vessels or organs, and the typical facial appearances, which we will have a look at in just a second. So here's a sort of in cartoon format, a description of some of these signs and symptoms. So again, the facial features, which consist of a thin nose, large eyes, and a small chin, the thin, see-through, elasticy skin, and the premature aging of the skin of the hands and feet. So that's acrogeria, and I'll show you a picture of that in just a second. And then over on the right, you see some of the consequences of the tissue fragility, including pneumothoraces and other organ ruptures. So this is the facial appearance that you may expect to see. So the thin nose, the very prominent eyes, the small chin, and then in the middle picture, the hand, which looks like the hand of an elderly person, but that is actually in a 20-year-old. So you can see the premature aging of the skin, and the translucency, where you can see all the vessels very prominently. And in the bottom picture, you can see the extensive marked bruising that's a feature of this condition. And there's just some more images, so you can see the blood vessels through the skin. And you can see the digital hypermobility. In the bottom, in the legs, there's a typical hemosiderin-filled bruising that is quite typical of classical and vascular type EDS. And then some of the faces, again, with the thin nose and the prominent eyes. So the minimum clinical criteria suggestive of vascular EDS would be both those features that we've just discussed, plus minus a family history of, in young people, arterial rupture or dissection, unexplained bowel rupture, or spontaneous pneumothorax. And these would prompt you to seek a molecular confirmation. So again, this is an autosomal dominant condition, so you'd expect to see a heterozygous mutation in the gene encoding type 3 collagen this time, so COL3A1. Moving on to hypermobility type EDS. So this is where it becomes much less clear-cut and rather more controversial. So unlike the other two conditions we've discussed, this is a entirely clinical diagnosis with no confirmatory backup testing. The clinical findings are soft and subjective. So what are they? Well, there are 3 criteria which must be fulfilled. So number 1 describes the joint hypermobility. So that is a Baton score of greater than 5/9 in children and adolescents. There is some discussion about increasing that to 6/9 to exclude a lot of healthy children, and over greater than 4/9 in older adults, because of the tendency to become less flexible with age. The second criterion, which must be fulfilled, for that you need to have at least 2 out of these 3, A, B, and C. So the skin signs, soft velvety skin, stretchy skin, striae, all quite subjective. Excuse me, I'll just advance that. for quite subjective signs, as I think you'll agree, and striae is something which we see very commonly in healthy children. You can have a family history of HEDS, but this can be self-reported and therefore self-diagnosed. And the MSK complications, which would be chronic pain, but also joint instability, which again can be self-diagnosed and self-reported. And I would certainly argue that a lot of people will get a clunking or discomfort in joints, which may be misinterpreted as subluxation or dislocation. And then the final criterion, which has to be met, is exclusion of other diagnoses. So moving on to the Baton score, which is obviously critical to all of this, it's at the basis of many of these diagnoses. It's often done wrongly. Helpfully in the Malfay classification, you do get these diagrams, and I just want to point out to focus on the first two images there. These show the importance of when you're testing for finger hypermobility, the forearm needs to be flat on a flat surface and pronated, and then you would need to see greater than 90 degrees angle of that digit to the flat surface. And in the second image with the wrist, the arm needs to be, the elbow should be extended and the arm pronated. And I think you will find, if you try this on yourself, that it's harder to get the alignment of the thumb to the forearm when your arm is out, extended at the elbow and pronated. So this is usually done incorrectly, and as a result, it is very often the score is very often overestimated. So those are the clinical criteria. However, this is a cause of some concern, which is that even if you do not fulfill those clinical criteria for hypermobility type EDS, you can still have, according to these patient groups, etc., a related diagnosis, a hypermobility related diagnosis. So they're now called the HSDs, or the hypermobility spectrum disorders. And they would include asymptomatic joint hypermobility, which I would argue is not a disorder or a condition at all. It's just a description of somebody in the flexible end of the normal spectrum, or non-syndromic hypermobility with secondary manifestations. So these are going to be vague, common symptoms, and there's an attempt to attribute them to one of these so-called hypermobility spectrum disorders. So my interpretation of that, not just mine, but our rheumatology community, is that there's an attempt to pathologize or medicalize these normal phenomena and to link with other common symptoms. And I think there are great concerns about that, which I will discuss in a bit. So hypermobility, is it a diagnosis? Patients will talk about being diagnosed with joint hypermobility. I would argue that it is not a diagnosis. It's not a condition. It's a normal variant in the spectrum of flexible joints, and it's actually an advantage in many people, athletes and dancers, etc. And as discussed previously, I think it is widely overcalled. There was a nice study done in the UK, the Avon longitudinal pediatric study. They took all children born in, I think, 1992, and they followed them up over decades and done all sorts of studies on them, including one where they took over 6,000 healthy 13-year-old children and did Beighton scores on them, and about a third of girls and 11% of boys were found to be hypermobile using the Beighton criteria. There was no associated symptomatology, apart from in a very small number, some anterior knee pain. So I think that very nicely demonstrates that this is a normal finding in healthy children. So I think that hypermobility is a distraction, it's a red herring, and there's been far too great a focus on it and a medicalization of an essentially normal phenomenon in many cases. So how does this present in rheumatology clinics? Certainly over here, we will see children with joint pains, and they've been told, or they think they are hypermobile, and they're concerned that this may mean that they have Ehlers-Danlos syndrome, or you may have an asymptomatic child. but there may be a family history, apparently, of EDS, either self-diagnosed or diagnosed by another practitioner. I will always ask what type of EDS has been diagnosed. It will invariably be hypermobility type, and who diagnosed it. There may also be a presentation of other features, non-MSK things such as dizziness, fatigue, etc. So all common, non-specific symptoms, all of which will be exacerbated by worry, by other psychosocial issues. And they're all symptoms which are difficult to either quantify or to disprove, if you like. So some families and children who come to our clinics with these constellation of symptoms are worried they may have EDS because they found it on Google. If you type in hypermobility on Google, you'll very quickly find yourself on an EDS website, and you'll also find yourself reading about terrifying consequences of other forms of EDS, such as vascular EDS, which of course can be very worrying. And some patients simply need a thorough assessment and reassurance and explanation. So often I'm saying, no, you don't have any condition, you don't have any underlying abnormality of your collagen that needs specific intervention or medical input. And often they're happy with that, and they may or may not need some physiotherapy if there's a lot of mechanical pain, but no further medical follow-up is needed. However, there are also other families where it's a bit harder and a bit more complicated. And I think that, not just I, this is not my own, I think this is quite widely held theory, but that there is and has always been, I expect, a population of people who have a lot of anxiety and worry and have other, what we would call biopsychosocial factors, which are too numerous to go into in the short talk today, but who are needing, very understandably, needing some kind of explanation, ideally a medical diagnosis, to explain their non-specific, probably anxiety-related symptoms, so such as chronic joint pains, recurrent abdominal pains, headaches, and dizziness. And in the past, some of the conditions that have been prominent in this desire to find a diagnosis would have been things like myalgic encephalomyelitis or chronic fatigue syndrome, and then chronic Lyme had for a while was a popular one, and now it seems to be Ehlers-Danlos's turn, if you like. But I do wonder whether in the near future, actually, there'll be a lot of overlap with so-called long COVID, because there's a lot of, again, non-specific symptoms, which there will be an attempt to attribute those to long COVID, whereas in fact, that may not be the case. So we'll watch this space and see whether EDS is usurped in favor of long COVID. So what you have is a so-called condition, hypermobility or hypermobility EDS, for which there are no diagnostic tests and which can't be excluded, plus a patient or family in need, seeking an acceptable explanation for some non-specific symptoms, plus social media, which amplifies all of this, plus a growing mistrust of experts, particularly medical experts, certainly here in the UK, but I imagine that this is a more widespread problem. And this creates a perfect storm leading to self-diagnosis, a boom in self-diagnosis via Dr. Google, the attribution of non-musculoskeletal symptom to so-called hypermobility EDS or other hypermobility spectrum disorders, reinforcement of these ideas via patient groups on social media, the rapid dissemination of disinformation, the challenging of medical professionals, and the reluctance to accept advice or explanations, particularly if there is any psychological component to that explanation. When I'm talking about the attribution of non-MSK symptoms, we will see some examples of these in the next slide. So These families and children may present to all number of different specialists, including orthopedic surgeons because of so-called dislocations, cardiologists for this thing called POTS, postural orthostatic tachycardia syndrome. So that's just dizziness on standing, which, as we know, is a normal physiological response to a drop in blood pressure, but which is more noticeable and more obvious in growing adolescents, but also in people who are inactive and physically deconditioned. And this can be over-medicalized and over-treated. They may present to gastroenterologists with so-called EDS-related gut dysfunction, which I think is just a fancier term for irritable bowel syndrome, which again we know is often linked with stress or anxiety. Other specialists that may see these patients, urologists with non-specific bladder or pelvic symptoms, allergy immunologists with itchy rashes, again stress-related, and general pediatricians and rheumatologists for a lot of asymptomatic children just seeking management of their EDS, even though they are asymptomatic. Why does it matter? Well, these children and their families may believe that they have a condition, and that this condition may be dangerous, may cause disability, and this can become a self-fulfilling prophecy, if you like. It may lead to this belief in having a disabling condition may lead to school avoidance, loss of education, lack of exercise and physical deconditioning, use of wheelchairs, etc., social isolation, multiple medical consultations and unnecessary investigation. So this is again the concern about the medicalization of this condition. And even more worryingly, unnecessary surgical procedures and interventions, medications such as the salt that I described for treatment of so-called POTS, and other forms of iatrogenic harm. And finally, another great concern that we have in the UK, which is being tackled by our Royal College, is where the diagnosis of hypermobility EDS or other hypermobility-related syndromes comes up against safeguarding or cases of potential non-accidental injury. So clearly there are children who, with classical Ehlers-Danlos syndrome, who bruise easily, who may have been wrongly diagnosed as non-accidental injury, and it's very important that that diagnosis is not missed in those children. But we've had other cases in the UK where a defense of hypermobility EDS has been used to explain widespread bruising in a child where it's the concern is of non-accidental injury. And these so-called expert witnesses who've talked about HEDS have in many cases been non-pediatricians or professionals with little or no expertise in non-accidental injury. And clearly that's of great concern to the pediatric community. So thank you for listening. I'd be very interested to hear what the people in other countries' experiences are, and I'd be very happy also to take any questions if there are any. Thank you very much.
Dear Professor Leahy, I can see your name during our participants. Thank you for joining us. Thank you for accepting our invitation. Such a great honor for us to have you here. It was really educational lecture, and it was really useful for me. Hello.
Hi, thank you. And thank you for inviting me.
Thank you for joining us. Dear Professor Sadeghi.
Okay. Hello, Alice. It's good to see you again.
Hi, I'm sorry about my brief attendance, but I have clinical commitments this afternoon.
No, thank you for your time. That was great. You know, most of the time when we think about a pediatric rheumatology meeting, we think about inflammatory disorders. But your presentation was great because it was some kind of the other aspect of the pediatric rheumatology that we are dealing with. we always have to think about non-inflammatory disorders when we see the patients who have some kind of challenging symptoms. You know, we are dealing with this kind of patients in our clinics very much because these diseases are very common among the populations. But I myself can say that I don't have enough experience with the Ehlers Danlos syndrome because I didn't see these patients very much. But we do have these patients, I mean hypermobility patients in our country very much. So, and you mentioned so many challenges that we are dealing with, because most of the time the parents got their information from internet, via internet, and most of the time they are misleading them, and we don't know what to do. And I think this is the duty of the professions to make very specific information about this disease via internet, and try to satisfy the patient and also the parents of the patients about the information, and to talk about the disorder, because it's not a disease. We can say this is some kind of disorder. So I learned about this disease, especially Ehlers-Danlos syndrome, through your presentation. And thank you again. And I don't know, is there any question, Dr. Kahramanlu?
No, the presentation was really complete, and I think there is no further questions. Thank you for joining us, and
thank you so much again, Dr. Leahy. And I think we are running out of time just at the end of the meeting. Again, okay, I should thank all the speakers and also all the attendees, because and also the executive team, especially Dr. Aghay, who raised the idea and now make the idea real for all of us, and also for the for the virtual meeting and also international meeting, and also okay, hello, Dr. Ravelli. Okay, and also my young colleagues in the hospital and also in the department, especially Dr. Kahramanlu. I know they made huge effort during the past 3 months for making this meeting available for every one of us, and in the end, thank all of you. Thank you so much.
Sorry for interrupting you, dear Dr. Sadeghi. There is a question from dear Professor Leahy. Okay. Dear Professor, okay. What is your concern about omega-3 in these patients?
Yes, I saw that question, and I'm not aware of any association. So I don't know, perhaps the questioner knows more than I do, but I don't know of any link between omega-3 deficiency and hypermobility type symptoms. So yeah, I'm sorry, but I don't know where that comes from.
Okay, thank you very much again. Thank you, dear Professor Bernal, dear Dr. Degraaf, dear Dr. Scott, and dear Dr. Leahy for joining us. At the end of the session, please, our Iranian participants, do not forget to join the exam in order to receive your CME credit, and please stay with us. We will be back in about 15 minutes with the next session of pediatric rheumatology arranged by dear Professor Ravelli. Good evening, good night, and good morning to everyone. I will pass the microphone to my dear friend Ehlers. Ehlers, good luck.
Thanks a lot, dear Mahia. Thanks a lot, dear awesome lecturers for the first session. In less than 15 minutes, we are going to be with you with updates on pediatric rheumatology, which is arranged and also will going to be managed by dear Professor Angelo Ravelli from Italy. Just we are going to have a break, approximately 10 minutes there, then we are going to be with you. Dear Professor